Okay, then I shall start on time. So, the topic today is diabetes mellitus, and we'll be discussing about the classification, the pathophysiology, and the clinical features. So, coming to diabetes mellitus, basically they are a group of common metabolic disorders. It shares the phenotype of hyperglycemia. Okay, so it's a metabolic disorder that shares the phenotype of hyperglycemia, and there are several distinct type of diabetes, and it is caused by a complex interaction of genetics and environmental factors. So depending on the etiology of diabetes, factors contributing to hyperglycemia include reduced insulin secretion. There could be a decreased glucose utilization and increased glucose production. The metabolic dysregulation associated with diabetes causes secondary pathophysiological changes in multiple organ systems, okay, and that can impose a tremendous burden on the individual with diabetes and on the healthcare system. So coming to the classification, so it is classified on the basis of pathogenic processes that lead to hyperglycemia, and not like how it was proposed earlier according to the age of onset or type of therapy. There are two broad categories of diabetes, which is designated as type 1 diabetes mellitus or type 2 diabetes mellitus. But however, there's an increasing recognition of other forms of diabetes are also emerging, in which the pathogenesis is also better understood now. So these other forms of diabetes may share features of type 1 and or type 2 diabetes mellitus, the new ones that are emerging. So both type 1 and type 2 diabetes are preceded by a phase of abnormal glucose homeostasis as the pathogenic process progresses. So always when it is a full-fledged or full-blown diabetes, before it emerges as a overt diabetes, there is a phase of abnormal glucose homeostasis that is going on in the body before it presents as an overt diabetes mellitus. Okay, so in type 1 diabetes mellitus, it is the result of a complete or a near total insulin deficiency is there. So this is an table which will give you a lot of clue about the types of diabetes. Here we can, here we can see the type 1 diabetes mellitus, the type 2, there are other specific types of diabetes. We have the gestational diabetes mellitus that you see in pregnancy. So in this table, then you have the normal glucose tolerance, okay, and then you can see the pre-diabetes value, or it is also called as, in some places, like according to the World Health Organization, it is called as, the term is increased risk for diabetes, or intermediate hyperglycemia also is the alternate names that is used for pre-diabetes. With there's a pre-diabetes, as then there is a full-blown or full-fledged or overt diabetes mellitus. So here you can see the arrows here in type 1. It goes into a, this arrow is unidirectional. Okay, so insulin is required for survival in type 1 diabetes patients. In type 2, if the arrow is bidirectional, means it can go back to even a normal glucose tolerance also. From an overt diabetes, it can go back to a impaired fasting, as and it's possible that they even come back to a normal glucose tolerance also. Type 2 diabetes mellitus, same way other type of diabetes mellitus also, it's bidirectional, means from overt it can come back to a normal glucose tolerance. Then we have the gestational diabetes, is again bidirectional, it can come from, if from a normal glucose it goes to a pre-diabetes or impaired fasting or impaired glucose tolerance to a full-blown, it can be bidirectional and can even come back to a normal glucose tolerance. Okay, and over time as it passes, mostly like it is like insulin will be required towards the end, after many years, as the years progress with this diabetic disease. So these are the values of fasting glucose and normal glucose tolerance. The HbA1c must be less than 5.6, and the target should be 100. And in impaired, you can call it, or pre-diabetes, the HbA1c is between 5.6 to 6.9, and the glucose levels will be 100 to 125 fasting. And in overt diabetes, or it will be more than 7 HbA1c with a fasting glucose of 126. Then comes the postprandial, 2 hours postprandial. The normal glucose tolerance will be less than 7.8 with a 2 hours PP of 140 value. So this will be more, it'll be dealt or spoken more about in detail in when it comes to the diagnosis of diabetes. It will be explained in which is your tomorrow, I mean next class or next medicine class. It will be covered. So I'm not going much into the diagnosis of diabetes. Next, coming to the etiological classification of diabetes. So etiological classification, as I told you, the main broad categories are type 1 and type 2, and the other diabetes can have features of type 1 and type 2. In type 1 diabetes, what happens there is there's beta cell destruction there, and usually leading to absolute insulin deficiency. And two reasons for type 1 diabetes: either it is autoimmune or it is an idiopathic process. Second one is type 2 diabetes, and it may range from predominantly insulin resistance with relative insulin deficiency to a predominantly insulin secretory defect with insulin resistance. So then coming to the other types of diabetes which can show features of type 1 and type 2, they are the genetic defects of beta cell development or function characterized by mutations. Mutations in these genes: hepatocyte nuclear transcription factor, HNF4A, glucokinase. This is all called as maturity onset diabetes of the young, MODY1. If there is a genetic defect where there's a mutation in glucokinase, MODY2, then hepatocyte nuclear transcription factor 1A, then insulin promoter factor 1, and the list goes on. Mitochondrial DNA, proinsulin or insulin. Then there is a genetic defects in the insulin action, where there is type A insulin resistance, leptospirosis, Rapson-Mendenhall syndrome, lipodystrophy syndromes. There is also one term used here which is in terms of transient neonatal diabetes. So this is also one of the other specific types of diabetes, that's transient neonatal diabetes. Then there is disease of the exocrine pancreas, where there is pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, endocrinopathies, acromegaly, Cushing syndrome, glucagonoma, pheochromocytoma. It can be drug or chemical induced. These are the other types of diabetes because of glucocorticoids or nicotinic acid, thiazides, drug induced. Then coming to infections: congenital rubella, cytomegalovirus, Coxsackie virus. Viral infections can cause other types of diabetes. Then uncommon forms of immune mediated diabetes is the stiff person syndrome, anti-insulin receptor antibodies. Then we have the other genetic syndromes sometimes associated with diabetes, that is the Wolfram syndrome, Down syndrome, Klinefelter syndrome, Turner syndrome, Friedreich's ataxia, Huntington's chorea, Lawrence-Moon-Beidel syndrome. Okay, so then we have the gestational diabetes mellitus. So these are the etiological classification of diabetes mellitus: grossly type 1, type 2, and then the other specific types of diabetes where there is mutations or genetic defects of the beta cell development, where there are mutations and secondary causes because of some endocrinopathies or drug induced or infections or disease of the exocrine pancreas, gestational diabetes mellitus. All these are the other specific types of diabetes that can happen. So type 2 diabetes is a heterogeneous group of disorders characterized by variable degrees of insulin resistance, impaired insulin secretion, and it is an increased glucose production. And it is preceded by a period of abnormal glucose homeostasis, like I explained in the table, where patient can have impaired fasting glucose or an impaired glucose tolerance. And then over time, it presents as from pre-diabetes to a full-fledged or overt diabetes mellitus. Other types of diabetes, like I told, maturity onset diabetes of the young and the monogenic diabetes are subtypes of diabetes characterized by autosomal dominant inheritance, where there is early onset of hyperglycemia, usually seen in patients less than 25 years of age, sometimes a neonatal period, and has an impaired insulin secretion. Mutations in the insulin receptor cause a group of rare disorders characterized by severe insulin resistance. Also, I already explained all this. With this, can result from pancreatic exocrine diseases. Hormones can antagonize the insulin action. It can be as a result of endocrinopathies. And even in Japan, it has been noted a fulminant diabetes is seen. Acute onset type 1 diabetes is seen as fulminant diabetes, probably some viral infection that is of the islets of pancreas. It has been noted in Japan. Gestational diabetes, as I mentioned, glucose intolerance developing during pregnancy is gestational diabetes mellitus. Insulin resistance is related to metabolic changes of late pregnancy, and the increased insulin requirements may lead to impaired glucose tolerance or diabetes. Most women, they revert to normal glucose tolerance postpartum, but have a substantial risk of about 35 to 60% of developing diabetes mellitus in the next 10 to 20 years. So patients who have gestational diabetes, they have to keep a watch. They have found in studies that they can develop a risk of developing full-blown diabetes over the next 10 to 20 years. Coming to pathogenesis. So pathogenesis of type 1 diabetes mellitus. So type 1 diabetes mellitus is a result of interaction of genetic, environmental, and immunological factors that ultimately lead to the destruction of the pancreatic beta cells and insulin, and thus resulting in insulin deficiency. So like I told you in the etiology, it can be autoimmune or it can be idiopathic. So there is complete destruction of the pancreatic beta cells here. And in type 1 diabetes mellitus, they can develop at any age, but most commonly before 20 years of age. And worldwide, the incidence is increasing at a rate of 3 to 4% per year. It results in the autoimmune beta cell destruction, and most but not all individuals have evidence of islet-directed autoimmunity. So it can be there are some idiopathic reasons also, causes also, which we are not aware of. So coming to this chart here, we can see the temporal model for development of type 1 diabetes. So here you see in this the vertical, there's a beta cell mass, and the horizontal, there is the time or over years. So usually they can have a genetic predisposition, these patients, type 1 with type 1 diabetes, and some immunological trigger is there. So after that, immunological abnormalities, progressive impairment of insulin release. So here you can see the beta cells are getting destroyed completely. There is a dip here, and ultimately there are no more beta cells left. It's all destroyed, and thus patient lands up in an overt or full-fledged diabetes with the for a bit of time after the trigger. There will be few beta cells left to act. After that, they are left with no more beta cells to release insulin, and patient develops an overt or full-fledged diabetes. So in susceptible individuals, this autoimmune process is thought to be triggered by an infectious or environmental stimulus and to be sustained by beta cell specific molecule. In the majority of patients, autoantibodies against beta cell antigens appear after this triggering event, followed by progressive loss of insulin secretion. The rate of decline in beta cell mass varies widely among individuals, with some patients they progress rapidly to clinical diabetes and others evolving to diabetes more slowly. So features of diabetes do not become evident until a majority of beta cells are destroyed. For about 70 to 80% of the beta cells are destroyed. At this point, residual functional beta cells exist but are insufficient in number to maintain the glucose tolerance. The events that trigger the transition from glucose intolerance to diabetes are often associated with increased insulin requirements, as might occur during infections or puberty. So remember, these patients are young, below 20 years, and the increased insulin requirements are there. Usually they're detected during some viral insult or during some surgery. Sometimes these patients land up in decay, and it is found out this trigger that happens. So after the initial clinical presentation of type 1 diabetes, a honeymoon phase is there. So during which time the glycemic control is achieved with modest doses of insulin, or rarely insulin is required at that time. However, this fleeting phase of endogenous insulin production from residual beta cells disappears and the individual becomes insulin deficient completely. So in between, they'll land in full-fledged type 1 diabetes, full-fledged diabetes. Then they'll have a honeymoon period where they barely require any insulin. And then comes the third phase where again they go back to square one, where the residual beta cells disappear and the individual becomes insulin deficient. Many individuals with long-standing type 1 diabetes produce a small amount of insulin as reflected by the C-peptide production. So if C-peptide levels, usually we check if C-peptide is there, then in sufficient amount, that means C-peptide usually produces levels we check in the blood to see whether the that means the pancreas is producing insulin. So if it is very low, that means the beta cells are destroyed. So we do check for C-peptide values to see whether they are producing insulin or not. We look for the C-peptide levels in the blood. Now coming to genetic considerations. So this susceptibility to type 1 diabetes involve multiple genes, and the concordance of type 1 diabetes in identical twins ranges from 40 to 60%, indicating that additional modifying factors are likely involved in determining whether diabetes develops. So there are additional modifying factors are involved. The major susceptibility gene for type 1 diabetes is located in the HLA region on the chromosome 6, and polymorphisms in the HLA complex account for 40 to 50% of the genetic risk of developing type 1 diabetes mellitus. This region contains genes that encode the class 2 major histocompatibility complex molecules which present antigen to the helper T cells and thus are involved in initiating the immune response. The ability of the class 2 MHC molecules to present antigen is dependent on the amino acid composition of their antigen binding sites. Amino acid substitutions may influence the specificity of the immune response by altering the binding affinity of different antigens for class 2 molecules. So most individuals with type 1 diabetes mellitus have the HLA-DR3 and or DR4 haplotype. And the refinements in genotyping of HLA loci have shown that the haplotypes DQA10301 are most strongly associated with type 1 diabetes mellitus. These haplotypes are present in 40% of the children with type 1 diabetes mellitus as compared to 2% of the normal US population. However, most individuals with predisposing haplotypes do not develop diabetes. In addition to the major histocompatibility class 2 associations, genome association studies have identified at least 20 different genetic loci that contribute susceptibility to type 1 diabetes mellitus. So genes that confer protection against the development of the disease also exist. And the haplotype, this DQA0102 is extremely rare in individuals with type 1 diabetes. Although risk of developing type 1 diabetes mellitus is increased tenfold in relatives of individuals with the disease, the risk is relatively low. So hence, most individuals with type 1 diabetes do not have a first degree relative with this disorder. Now coming to the pathophysiology. So although there was a genetic considerations, which is a bit too much, which is a bit too much in depth that is given in Harrison. You don't need to go into so much of depth. Now coming to the pathophysiology, although other islet cell types, alpha cells that is glucagon producing, the delta cells which is somatostatin producing, and the pancreatic polypeptide producing cells are functionally embryologically similar to beta cells, they're spared from the autoimmune destruction. Pathologically, the pancreatic islets have a modest infiltration of lymphocytes, a process termed insulitis. After beta cells are destroyed, it is thought that the inflammatory process abates and the islets become atrophic. So what happens here is the pancreatic islets, they become infiltrated with lymphocytes, and so after the beta cells are destroyed, they're filled with lymphocytes, and that's how the islets become atrophic. Now, studies of autoimmune process in humans and in animal models of type 1 diabetes, which was done in mouse and rat, have identified the following abnormalities in the humoral and cellular arms of the immune system. Islet cell autoantibodies, activated lymphocytes in the islets, T lymphocytes that proliferate when stimulated with islet proteins, release of cytokines within the insulitis. Now, beta cells seem to be particularly susceptible to the toxic effect of some cytokines, that is tumor necrosis factor, interferon gamma, and the interleukin-1. The precise mechanisms of beta cell death are not known, but may involve the formation of nitric oxide metabolites, apoptosis, and direct CD8 8 T cell cytotoxicity. The islet cell destruction is mediated by T lymphocytes rather than islet autoantibodies, as these antibodies do not generally react with the cell surface of islet cells. Now coming to immunological markers of islet cell autoantibodies, here a composite of several different antibodies directed at pancreatic islet molecules such as GAD, insulin, ZNT8, and they serve as a marker of the autoimmune process of type 1 diabetes mellitus. The assays for autoantibodies to GAD65 are commercially available. The testing for immunological markers, islet cell antibodies, can be useful in classifying the type of diabetes as type 1 and in identifying non-diabetic individuals at risk of developing type 1 diabetes mellitus. ICAs are present in the majority of individuals, more than 85% diagnosed with new onset type 1 diabetes mellitus, in a significant minority of individuals newly diagnosed type 2 diabetes mellitus, and occasionally in individuals with gestational diabetes mellitus. So these are the composite different antibodies directed at the pancreatic islet molecules. Now coming to environmental factors which trigger, like already explained in the in the table, there could be viruses like Coxsackie, rubella, bovine milk protein, vitamin D deficiency, environmental toxin, nitrosourea complex. All these environmental factors can trigger type 1 diabetes, and identification of an environmental trigger has been difficult because the event may precede the onset of diabetes mellitus by several years. So coming to type 2 diabetes mellitus, its pathophysiology. So here, insulin resistance and abnormal insulin secretion are central to the development of type 2 diabetes mellitus. Although the primary defect is controversial, most studies support the view that insulin resistance precedes an insulin secretory defect, but that diabetes develops only when insulin secretion becomes inadequate. Type 2 diabetes mellitus likely encompasses a range of disorders with common phenotype of hyperglycemia. So coming to genetic considerations, here type 2 diabetes has a strong genetic component. Unlike type 1, the concordance of type 2 diabetes mellitus in identical twins is between 70 and 90%. Individuals with a parent of type 2 diabetes mellitus have an increased risk of diabetes. If both parents have type 2 diabetes mellitus, the risk approaches by 40%. Insulin resistance, as demonstrated by reduced glucose utilization and skeletal muscle, is present in many non-diabetic first-degree relatives of individuals with type 2 diabetes mellitus. The disease is polygenic and multifactorial because, in addition to genetic susceptibility, environmental factors such as obesity, nutrition, and physical activity modulate the phenotype. Also, the in utero environment contributes, and either increased or reduced birth weight increases the risk of type 2 diabetes mellitus in adult life. The genes that predispose to type 2 diabetes mellitus are incompletely identified, but recent genome-wide association studies have identified a large number of genes that convey a relatively small risk for diabetes mellitus, more than 70 genes, each with a relative risk of 1.06 to 1.5. Genetic polymorphisms associated with type 2 diabetes mellitus have also been found in the genes encoding the peroxisome proliferator activated receptor gamma, inward rectifying potassium channel, zinc transporter IRS, and calpain 10. The mechanisms by which these genetic loci increase the susceptibility to type 2 diabetes mellitus are not clear, but most are predicted to alter islet function or development of or insulin secretion. Coming to pathophysiology. Pathophysiology of type 2 diabetes mellitus is characterized by impaired insulin secretion, insulin resistance, and excessive hepatic glucose production and abnormal fat metabolism. Obesity, particularly visceral or central, as evidenced by the hip-waist ratio, is very common in type 2 diabetes mellitus. More than 80% of the patients are obese at the time of diagnosis. In the early stage of the disorder, glucose tolerance remains near normal despite insulin resistance because the pancreatic beta cells compensate by increasing insulin output. As insulin resistance and compensatory hyperinsulinemia progress, the pancreatic islets in certain individuals are unable to sustain the hyperinsulinemic state. So here we can see in this graph This is the metabolic changes during the development of type 2 diabetes mellitus. Here we can see the insulin secretion on in the vertical side, and the horizontal we can see the insulin sensitivity. They both are interrelated. The insulin secretion and insulin sensitivity both are interrelated. So here we can see from here there's a normal glucose tolerance, and as it progresses from A to B, there's a normal glucose tolerance, and from B to C there is impaired glucose tolerance, and then there is type 2 overt type 2 diabetes mellitus. So as the insulin secretion is increasing and the insulin sensitivity is decreasing, here the insulin sensitivity is decreasing and the insulin secretion is increasing, patient from B to C to D, patient goes into overt diabetes mellitus. So as an individual becomes more insulin resistant by moving from point A to B, the insulin secretion increases. He is becoming more insulin resistant. A failure to compensate by increasing the insulin secretion results initially in impaired glucose tolerance test, like I told. Impaired glucose tolerance is characterized by elevations in the postprandial glucose. Then develops a further decline in insulin secretion, and an increase in hepatic glucose production leads to overt diabetes with fasting hyperglycemia. Ultimately, the beta cell failure ensues. So over years, ultimately the patient will require insulin, as told in the earlier table. Although both insulin resistance and impaired insulin secretion contribute to the pathogenesis of type 2 diabetes mellitus, the relative contribution of each varies from individual to individual. So some patients will be more sensitive to insulin. So it differs from patient to patient, from individual to individual. So coming to metabolic abnormalities, here the fat and muscle metabolism. Insulin resistance, the decreased ability of insulin to act effectively on the target tissues, especially muscle, liver, and fat, is a prominent feature of type 2 diabetes mellitus and results from a combination of genetic susceptibility and obesity. Insulin dose response curves exhibit a rightward shift indicating reduced sensitivity and a reduced maximal response indicating an overall decrease in maximum glucose utilization, 30 to 60% lower than in normal individuals. Insulin resistance impairs glucose utilization by insulin-sensitive tissues and increases hepatic glucose output. Both effects contribute to the hyperglycemia. Increased hepatic glucose output predominantly accounts for increased fasting plasma glucose levels, whereas decreased peripheral glucose usage results in postprandial hyperglycemia. In skeletal muscle, there is a greater impairment in non-oxidative glucose usage, glycogen formation, than in oxidative glucose metabolism through glycolysis. Glucose metabolism in insulin-independent tissues is not altered in type 2 diabetes mellitus. The precise molecular mechanism leading to insulin resistance in type 2 diabetes mellitus has not been elucidated. Post-receptor defects in insulin-regulated phosphorylation dephosphorylation appear to play the predominant role in insulin resistance. Abnormalities include the accumulation of lipid within skeletal myocytes, which may impair mitochondrial oxidative phosphorylation and reduce insulin-stimulated mitochondrial ATP production. Impaired fatty acid oxidation and lipid accumulation within skeletal myocytes also may generate reactive oxygen species such as lipid peroxides. Hyperinsulinemia may increase the insulin action through these pathways, potentially accelerating diabetes-related conditions such as atherosclerosis. The obesity accompanying type 2 diabetes mellitus, particularly in a central or visceral location, is thought to be a part of the pathogenic process. In addition to these white fat deposits, the humans now are recognized to have brown fat, which has much greater thermogenic capacity. The increased adipocyte mass leads to increased levels of circulating free fatty acids and other fat cell products. For example, adipocytes secrete a large number of biological products. For example, the non-esterified free fatty acids, the TNF-alpha, the leptin, adiponectin. So in addition to regulating body weight, appetite, and energy expenditure, adipokines also modulate the insulin sensitivity. The increased production of free fatty acids and some adipokines may cause insulin resistance in skeletal muscle and liver. For example, free fatty acids impair glucose utilization in the skeletal muscle, promote glucose production by the liver, and impair beta cell function. In contrast, the production by adipocytes of adiponectin and insulin sensitizing peptide is reduced in obesity, and this may contribute to hepatic insulin resistance. The metabolic environment of diabetes may also negatively impact islet function. For example, chronic hyperglycemia paradoxically impairs islet function, glucose toxicity, and leads to worsening of hyperglycemia. Improvement in glycemic control is often associated with improved islet function. In addition, elevation of free fatty acid levels, lipotoxicity, and dietary fat may also worsen islet function. The lipid storage or steatosis in the liver may lead to non-alcoholic fatty liver disease, NAFLD, and abnormal liver function test. This is also responsible for dyslipidemia found in type 2 diabetes mellitus, where you can see in fasting lipid profile there's elevated triglycerides, reduced HDL, there's increased LDL. This is the bad cholesterol. So coming to insulin resistance syndrome, the insulin resistance condition comprises a spectrum of disorders with hyperglycemia representing in one or more readily diagnosed features. The metabolic syndrome, just to mention about it, is also called as insulin resistance syndrome or syndrome X, where there's a constellation of metabolic derangements that include insulin resistance, hypertension, dyslipidemia, decreased HDL, increased LDL, and elevated triglycerides, central or visceral obesity, type 2 diabetes mellitus, or impaired glucose tolerance, impaired fasting glucose, and accelerated disease. Now coming to clinical features, which is the last part. In type 1 diabetes, usually it begins before the age of 40. Here the body habitus is normal to wasted. The onset of symptoms is abrupt with polyuria, polydipsia, polyphagia, and weight loss, which develops over days to weeks. Occasionally an initial episode of usually in type 1 diabetes mellitus, they present with diabetic ketoacidosis. And type 2 diabetes mellitus, it usually begins after the age of 40, and typically patient is obese at presentation. Unlike type 1 diabetes mellitus, the symptoms usually begin gradually over months to years. Frequently hyperglycemia is detected in an asymptomatic person on routine examination. Patients may have no symptoms, but ideally patients with diabetes, they can ask symptoms of increased appetite, increased hunger, passing of too much of urine, or drinking lots of water, the feeling of thirst. So these are the three main symptoms you can ask whether the patient is experiencing or not. But most of the times they may consider it as normal, but you must ask these symptoms. These are the classical symptoms if you suspect diabetes in a patient with suspected diabetes mellitus. But most of the times patients consider all this normal and they go on with their routine life, and usually hyperglycemia is detected on they may consider these symptoms as normal, and on routine examination diabetes is detected. Also, many patients present in one of the chronic complications of diabetes, they may consider all this as normal, and they may be carrying the disease for over a period of years, and ultimately the complications set in, and they may present in the complications of diabetes, and on investigations they're found to be diabetic. So over years it affects the nerves, the eyes, the kidneys. So they may present with some eye complaints, or they may present with non-healing ulcers, delayed wound healing, or they might complain with neuropathy. They may complain of numbness over the legs and hands. So they may present even ultimately once they reach the complications of uncontrolled diabetes. After many years, they may be diagnosed. Depressed immune system status may result in flare-ups of pulmonary TB, non-healing wounds. So having diabetes mellitus is actually a immunocompromised state. So all this can result in because of the depressed immunity, they can land up in they can catch infections easily. So they may have flare-ups of pulmonary TB or non-healing wounds, recurrent styes in the eyes, recurrent UTI, candidial pruritus, vulvae. So they may present in these, and mostly the complication of type 2 diabetes mellitus is that the ultimate complication is HONC, hyperosmolar non-ketotic coma. So that is, and usually type 1 diabetes mellitus patients, they end up in diabetic ketoacidosis. Not that type 2 diabetes mellitus patients can't develop in, can't land up in DK, but commonly, what is more commonly found. So that comes to the end of the presentation. If you have any doubts, please let me know. Then I think we'll bring the session to a close. Thank you.